It's a pleasure to present Silvia Pérez. Silvia Pérez is working in Inveniam, and she is a medical engineer and a strategic consultant with more than 4 years experience in medtech, biotech, and digital tech. And she has experience also in go-to-market and business strategy, proven success in securing public funding, and doing this advisement, and for different companies to raise private fundraising. And in general, she has this expertise in market access and in health economics, And today, Silvia will talk about this interesting topic and try to unveil, which is the concept of willing to pay, specifically in pediatrics, and try to demonstrate, how it can be integrate all of these concepts, into an early stage of economics evaluation of your projects. With this, thank you, Silvia. And I stop to share my screen, and the floor is yours.
Okay, perfect. Thank you, Raquel. Let me know if you can see properly my screen before starting. Okay.
We can.
Thank you. So good afternoon, everyone. It's a pleasure to be here, and thank you for joining the training capsule. So as Raquel was mentioning, today we will explore how this concept of willingness to pay applies to the pediatric healthcare specifically, how it can support early economic evaluation, and how to design this willingness to pay in a preliminary way in order to use it for practical tools, as the ones Raquel was mentioning, because as you know, this can be applied not only to the interest of your project, but also in order to convince other stakeholders of the environment, like investors, public funding entities, etc. So I will go through the presentation a bit regarding the objective of today. So the idea is not to overwhelm you with complex or abstract economic concept, but our goal is to provide this practical and introductory foundation on willingness to pay studies, particularly to the pediatric healthcare innovations. So this will help you understand why these studies are essential when developing new technology. And beyond developing a great innovation, we must also assess whether the technology addresses this unmet clinical need, who the final customer or decision maker is, and most importantly, whether they are able or willing to pay for it and how much. So these understandings for sure will be key to ensure that we are moving in the right direction. So I will go briefly through the agenda of today's session. It's more or less these 45 minutes that Raquel was explaining, and for sure, please, happy to receive all your questions at the end. So the idea is that we will start with this basics understanding of the willingness to pay applied to pediatrics, just to show you a bit of the concepts that we normally use. Then we will go briefly through the different methods that we have to measure this willingness to pay, and this will lead us to explain you a practical case considering one of the methodologies that we suggest for early projects in any kind of innovation in order to start on this willingness to pay conception. So also from this, we will explore a bit how this willingness to pay as a preliminary evaluation will evolve into the early health economics that you are maybe more used to this now. And at the end, we will have for sure a round for questions, answers, and anything that you may need on this. So I will go through the first section now. First, in order to introduce to you the topic, I was thinking that you need to understand that willingness to pay refers to the maximum amount that someone is willing to pay for a product or service that provides a health benefit. So it's not what it should cost, it's not how much money, I don't know, the producers want to earn, it's what really people are willing to pay if they perceive it's worth it. And this can be applied to a lot of phases of life, let's say. So this willingness to pay helps answer the crucial questions about, is this product or this innovation worth the money from the different perspectives like users, health providers, or even insurers in the case of technologies like the ones that we are going to discuss today. So just to put it a bit briefly with an everyday example, imagine that you have, I don't know, fever or a sore throat. You need medicine, and these are two options available. Option one is a medication that costs, for example, $3 and takes 3 days to make you feel better. And the option two is the same another medication, that costs $12, but it works in 12 hours. So now you as customers are decided what to buy. For sure, the first option is cheaper, but the second one offers quicker relief. So the question is, how much will you pay for a faster acting medicine? So maybe this $12 feels fair, but you wouldn't pay $30 for the same effect, right? So your willingness to pay here depends on the value you place on the speed of your recovery, and maybe you have an important meeting or whatever tomorrow, so the faster relief is worth more to you. So this is basically the essence of the willingness to pay applied to a really simple example. Is the trade-off between the price and the value you will get in return. If we apply this to the healthcare context, especially in pediatrics, for example, willingness to pay takes on a broader and more complex meaning. Here we have some of the key actors involved, as you can imagine, like, for example, families. Parents of sick children might be willing to pay more for a solution that is less invasive, faster, more comfortable. For example, they might pay extra for a device that monitors their child's health at home, reducing hospital visits, etc. On the other hand, we also have to involve other actors like doctors or hospital, because they may be willing to invest in technologies that improve patient outcomes or reduce long-term costs. For example, this same device that monitors a child's vitals and prevents complications could be worth a high upfront investment if it leads to fewer hospitalization, and this all applies to the cost of the overall management, let's say. And for sure, as a third step, we also have another stakeholder, that is the public health in general or insurance. Governments might also have this willingness to pay, but their focus is often on the cost effectiveness on this treatment. This is a concept that we will maybe come back at the end of the session to explain better in detail. So these actors will look at whether a new technology saves money in the long run by preventing more expensive treatments, hospital stays, or surgeries, and this will be, let's say, the key indicator that may then decide in order to invest public money or not. But first, we should maybe reflect a bit about why is willingness to pay important in healthcare, and how maybe this is a key thing that will follow along all the sessions. So for sure, in order to understand the market demand, willingness to pay helps determine if there is a real market for your product or service. If parents or hospitals aren't willing to pay for the technology, it's a clear signal that either the product needs to be improved or the business model needs to change. On second place, for sure, to inform pricing strategy. As you know, even though that science is really important, you need to accurately measure your pricing strategy before starting conversation with key opinion leaders, investors, the ecosystem, in order to reach the market. So willingness to pay can help guide pricing decisions. It will help you know if you are pricing too high or too low based on what your customers value. For example, for a pediatric device is high, you may be able to say set a higher price depending on the feedback. So this also will be guided by the willingness to pay exercise. For sure, as a third pillar, it's to support funding decisions. Investors and healthcare providers, as we were commenting, often rely on this willingness to pay studies to decide whether to fund or adopt a new healthcare technology. And here we will discuss, but you can find different, let's say, levels of willingness to pay in order to convince both stakeholders. If the willingness to pay isn't high enough, it may be difficult to attract investment or secure reimbursement from insurance, and this will be a key element in defending your project in front of these stakeholders. And for sure, the last point is the negotiation with these final payers. The willingness to pay will provide you this evidence during the negotiation with these stakeholders in order to show that your technology provides enough value for the cost, and that you will be in a stronger position to negotiate pricing, reimbursement, or funding, and advance in the different milestones in order to reach the market. So, for example, let's also back to an example case. Imagine that you have created, Imagine that we can focus on something more closer to home. So imagine that you are a startup that have built a smart baby monitoring for premature infants, this is going to be used at home after hospital discharge. This can give you, for example, as a value proposition, real-time alerts, tracks vitals, exactly the kind of thing that you could reduce stress for parents and lower readmissions for hospital. It's a smart baby monitor, so this sounds like a dream for anxious parents, right? But here's the question, who pays? Maybe the hospital system sees long-term savings, but doesn't have a funding mechanism, as it happens sometimes in Spanish environment in public healthcare, or maybe the parents love the idea, but balk at the monthly subscription, or maybe insurance companies need more proof of effectiveness before they say yes. So with this willingness to pay, you can ask parents, doctors, hospital directly. How much will you pay for a peace of mind? You will learn that parents are willing to pay maybe 20 euros a month, but not 50, or that hospitals will find it, but only if it reduces an exact percent, the readmissions. So this is gold for your business model and pricing strategy, because this is where willingness to pay comes in. So as you can see on the screen, a willingness to pay well-designated study can help the team understand what the stakeholders are willing to pay and under what conditions. And this information is essential for building this viable pricing and reimbursement strategy. And for sure, avoid any surprises when the product hits the market. So, for example, by understanding how much people, hospitals, or insurers are willing to pay for technology, we can design better products that meet real needs, set fair prices that are aligned with market demands, or ensure that the technology is financially sustainable and accessible. So, without the understanding of this willingness to pay, we risk developing products that no one can afford or that fail to meet the needs of people who will benefit most. So, exactly in pediatrics, are we going to discuss a bit why this willingness to pay has to take a look differently. As you know, it's a particularly complex because decisions are often not made solely based on rational economic factors, but also involve emotional and ethical considerations. In this case, we have to take into account that we have to consider caregivers' perspective. So in willingness to pay in pediatrics often reflects the values and perceptions of the caregiver, usually parents or guardians, who are making the purchasing decision for the child's health. So caregivers typically make decisions based on what they believe will improve the child's quality of life, and the emotional connection with the child can make this willingness to pay significantly higher than other solutions in the field because it promises relief or health benefits. So, for example, let's consider the initial case that we discussed. If this medicine for the sore throat is just for you, you might think twice about paying extra for something, right? But what if it's for your child? Suddenly, this premium price feels a little scary, and parents will probably drop that extra cash in a heartbeat for a medication that promises to make their little one feel better, faster, or have a more comfortable experience. Because when it comes to the kids, we are about whatever it takes mindset. So, for example, we have to consider this, and also the fact that parents and caregivers often, for example, have a highly emotional state when their child is ill, and this can develop fear of health risk that raise the willingness to pay significantly. Caregivers might be willing to pay for an innovative therapy if it prevents a serious or long-term condition or improves survival chances. So we have to think also about it when we are considering the threshold that we place. And for sure, we have to also consider the ethical sensitivities around monetizing the children's health outcome. So stakeholders, such as healthcare providers and pharmaceutical companies, need to be extra cautious when setting prices to avoid the perception of exploiting vulnerable population. So this is particularly sensitive in pediatric healthcare, where the patients are children who often can advocate for themselves. So in this situation, caregivers who are emotionally invested in their children's health are the ones making financial decisions. And here, for example, I just want to show you a case that maybe some of you already know about, and it was the EpiPen price scandal. This was a device that was used for emergency treatment for severe allergic reactions that became the center of this major controversy in 2016 because of the price. So what happened? The pharmaceutical that was below it, Mylan, raised the price from around $100 for nearly $600 in 2016. So this price increase, which was seen as an excessive for an essential medication, leading to widespread criticisms. So for this, especially because this is a critical treatment for children with severe allergies, families who relied on the device face a step out-of-pocket cost, and this case drew national attention because of law makers, health professionals, and the public accusing Mylan, the pharmaceutical, of price gouging. So the result was on the public that Mylan was forced to offer a generic version on the EpiPen at a lower price and to provide these discount cards to make the device more affordable for patients. However, the damage that the company received for this reputation was significant, and this incident highlighted the ethical issues involved in pricing, essentially when health products are for vulnerable groups like children. But not only this affect only price, it was also something that we can analyze from a market strategy perspective. In this case, for example, alongside the price increase, Milan undertook an aggressive campaign to consolidate its dominance in the market and expand the perceived needs of these products. Even they partnered in 2014, I think, with Walt Disney in order to create a dedicated website, a storybooks distributed along these allergies for family, and to increase the awareness. So this is a prime example of how willingness to pay can be shaped, not just by the intrinsic value of the therapy, but also by how the urgency is perceived in case of the childhood, how the emotional marketing you are receiving, in this case, with other partners like Disney that are really well known, and how institutional policies can influence public behavior and spending. So after this brief introduction, we are going to enter a bit about which willingness to pay types do we have and the methods in order to measure them. So as you can imagine, willingness to pay is not a one-size-fits-all concept. It depends on what, why, and how we ask. So when talking about it, it's important to understand that there are different types or dimensions depending on the context and the stakeholder. So breaking down a bit, we have a first case, a stated willingness to pay. What people say that they are willing to pay. And this is more common use in surveys and interviews. It reflects an hypothetical or self-reported preference. For example, a parent might say that they are willing to pay $500 for a new therapy for their child, but when they face it with a real bill, they might hesitate. So this has the strength that is easy to collect and useful for early stage evaluations, but can be biased by emotions. Then other type of willingness to pay is a reveal one, what people actually do pay. This is based on the real world behavior, purchases, insurance claims, co-payments. This is used often in retrospective studies or market analysis. For example, if 80% of parents purchase a therapy despite its high cost, that gives us an insight into actual willingness to pay. So as you can imagine, this is more reliable, but it's hard to measure in early stage innovation on when access is limited. And the third case is the emotional or ethical one, what people feel they should pay even if they can't afford it. So for example, this has emotionally charged context that may inflate perceived value. Parents may report very high willingness to pay even in low income settings, and it's important to consider in how we interpret results. It doesn't always reflect true affordability or market viability. But let's put a bit this theoretical concept into something that we can measure with examples. So now are we going to enter into 4 of the most used methods in order to measure willingness to pay, and that we will explain later, which is the one that we have chosen for the example. The first one is the contingent evaluation, or most commonly known as direct survey method. So you can ask respondents directly, how much will you pay for this? And they will provide a stated preference. This is an open question with payment cards or binding gains even. So for example, you can say, imagine a new nasal spray that could reduce your child's hospital visits. What's the maximum you will pay for a monthly supply? So this is simple, this is quick to implement, and this is intuitive, but it's based on an hypothetical bias, and it has other strategic responses that you may not be able to get. So in order to implement this, we'll have to be careful, specifically on pediatrics, because how you phrase the questions, emotional framing can greatly influence the responses when it involves children, as this is also on a direct basis. On another scenario, we can have another method that is based on discrete choice experiments or the preference-based method. And you can imagine this offers a preference between 2 hypothetical options with different attributes and prices, so you can state a preference and indirectly reveals the willingness to pay. An example will be, for example, respondents choose between options like 100-month treatment, 90% efficacy, or $50 a month treatment with 70% efficacy. So as you may imagine, this is a statistical model estimating how much people value each feature. In this case, the efficacy versus the cost. So this requires more time and cognitive effort from respondents, and is complex to analyze. In pediatrics, for example, this can be useful to understand which therapy features matter most to the caregivers, less pain, of administration, fewer side effects, in order to also, if you are developing a new therapy or a new product, be able to include those features in the value proposition of the service that you are offering. Then, for example, also, we can go into detail into a qualitative approach. understanding the why behind this willingness to pay. For example, you can create these deep interviews or focus group with specialists, with patients, or with parents to explore the motivations behind that. So normally you guide these open discussions with a semi-structured guide in order to have, like, I don't know, 1 hour, 2 hours of discussions, and you will receive these nuanced insights into attitudes and context. You will be able to further explore the reasons behind the preliminary agenda and go into detail. These often are more expensive, but it's good for early stage development because you will get the insights that you are searching for, and you will have the time to discuss with the key opinion leaders in a more detailed way. But the contrary is that you can't guide this conversation because there are no numerical willingness to pay, and you cannot generalize, find easily which concrete data you are searching for. So normally we used to suggest this qualitative approach for a later stage when you have more clear data on your technology. But on the pediatrics, for example, this will help to understand why a parent might value comfort or familiarity in a treatment beyond other measurable outcomes. And the fourth type, that is the one that we are going to go into detail today, is the quantitative digital surveys that are normally less long because you can, for example, have one into 10, 15 minutes, and they are delivered digitally. So this also helps in order to target concrete key opinion leaders or parents, and people are more willing to respond. So here, as we will show later, you can include different parameters that you want to measure, and you will make sure that you obtain the same amount of data from any respondent and in the same quantity in order to make more effective and to statistically analyze all the data and to have this fast and scalable final analysis. It also involves a low respondent burden because it's good completion rates and can capture these broad trends in the early development. But of course, the contrary is that this is normally based on hypothetical scenarios. You have this delimitation of the depth of the interview and doesn't explore any emotional drivers. So there is also a risk of low engagement if it's not well designed, and that's why you have to take into account different parts in order to be able to implement into your technology. As I was saying, this is perfect for early stage testing or on parental willingness to pay, on key opinion leaders for these innovative treatments in order to understand, for example, this quick feedback regarding reimbursement, pricing, the unmet need that you're facing, and what are the challenges that people may envision on your technology. So the idea of today's session is to provide you a real specific example. So here we are going to imagine a Spanish biotech, maybe from Catalonia, developing this hypothetical gene therapy for a rare neuromuscular condition in children. For example, they may aim to start in Spain, but then follow to near countries like European ones, and maybe, I don't know, let's say Mexico and United States. So the idea is to show you a bit of the different procedures that you might follow in order to conduct this early willingness to pay, to understand both pricing, reimbursement, and regional engagement and strategies ahead of market entry. So we are going to show not only the, let's say, the steps that you need to conduct, but also some final data that you will be able to analyze and that how it will support your health economics assessment later. So as you can imagine, the first step is to define the objective. What we want to learn, for example, how much will parents value a therapy that improves its mobility and delays disease progression. So for that, you need to define not only the objective of the survey, but also the definition of who are going to be the ones answering. Maybe you are looking for parents, you are looking for healthcare providers, but consider also involving some clinicians or insurance in some contexts can give you, let's say, a real world feedback. So the first of all, you need to decide is who is going to answer this query. And for sure, you have to select, let's say, the business case that you are going to present. Maybe you have this technology developed, but you don't want to, let's say, expose all the different developments that you have been acquiring, but you need to have a clear business case or value proposition so people can read to understand what is the competitive advantage or the solution that you want to measure. So as a next step, you need to decide who are you going to present the technology, but also the scope, the target regions. Maybe we can use the same example that we were mentioning, these near European countries, Mexico, US, and UK, in order to see in the first market strategy countries, which is going to be the feedback. here, for example, we are proposing, I don't know, a 50%, 50 QOLs and 10 per country in order to have a statistical significantly samples. And you have to define these two parts of the questionnaire. First will be a screening part where you are going to choose between all the respondents which are the pool that you are really targeting. Like, for example, key opinion leaders in this context. And then you will have a space for some open questions in order to directly get the answers that you are searching for in terms of the pricing, the reimbursement, and all the funding pathways in both these public environments in order to adopt your technology. Sorry. So here, for example, we are going to provide some ideas about how we will split the different parts. So as I was mentioning, first you will include, or we normally include these screening questions first for targeting key opinion leaders profile. As you can see here, one example is to include these kind of questions that can be 5, 10, in order to discrete and exclude those that are not fulfilling your request. So you will ask, are you familiar with gene therapy as a treatment approach for genetic disease? And you will get some answers. So from here, we normally exclude those that are not fulfilling what we are searching for. So we make sure that the final survey gets the respondent that we really want. So as you may see, for example, for these 50 key opinion leaders among the different countries that I have mentioned, we are only going to choose those ones that are familiar with this gene therapy as a treatment approach and that have really the knowledge about this kind of therapies in order to answer the query. Another typical screening question that you should include is about if they are really treating this kind of patients per year, and you more or less can also question that in order to see which are the key opinion leaders that has the higher patients of this time, and you maybe can discrete to only those ones that overcome a specific threshold. For example, also in order to assess really well if they are going to respond these questions regarding pricing, reimbursement, and decision-making process, we also include this screening question in order to assess the level of statement that describes their involvement into this decision-making around pediatric hospitals. So, for example, with this question, imagine that you have received feedback from the different parameters. You are only going to use for the final query those key opinion leaders that have a strong influence in the decision-making process or are part of the group that makes the decision, of if you are lucky that are the sole decision maker. So the idea is that when we are conducting this type of willingness to pay, we should be really careful in this part of screening in order to really target this group of people, of parents, key opinion leaders, or payers that are going to have the expertise and the knowledge to answer our questions, because therefore it will be the way that we are going to make sure that our answerings will be able to guide the decision that we take on the next steps. So these should be some examples about the screening part. And then what normally goes is when you are part into this open questionnaire, if you have really overcome the threshold previously described in the screening questions. So as you can imagine, for example, first we should include an introduction of your technology and this business case that I was mentioning in order to show the value proposition that it has, and also, for example, what is the difference between other competitors. And then you will be able to ask if people have to decide on this number how much they'll be willing to pay, either personally or through the healthcare system, for this specific therapy, offering some options. So as you can see here, this will be help you sorry, to discrete between the different options that they have and see a bit statistically among the respondents which are the tendencies. Also, normally you can include some kind of indicators in order to compare between different parameters, like, for example, the success rate, and if this will for sure have an influence on the final decision on the pricing. Another interesting way of doing this opening question is using this trade-off scenario, like as we were commenting before, offering this option A and option B options of the efficacy and the cost of the treatment, and see which are the tendencies among the population that you that you are searching. But not only price is the things that you can get from this kind of willingness to pay, also some idea or trends about the main challenges that you will encounter when implementing, imagine this gene therapy for a rare neuromuscular condition in children. So maybe you discover that apart from the cost and the accessibility, there are other factors that will limit your entry into this market. And this kind of willingness to pay in a preliminary way can also guide you on this. So as an example that you can see on the screen, maybe you will find that the regulatory challenge will be something that key opinion leaders will be interested to know before investing in these kind of technologies. Other people, maybe it's worry about ethical considerations. So by doing this kind of statistical analysis, you will get a glance about different approach, and you can also for sure go into detail after this into direct interviews to understand maybe the reason behind all of this and have a clear idea. And this at an earlier TRL between, for example, 4 to 6 will help you guide the development and the technical requirements of the technology in order to be aligned with this implementation into the market. So we have explained a bit about how this willingness to pay may be conducted in early stage. And we have seen an example of how, for example, caregivers may express their willingness to pay, and we can connect it to something incredibly valuable in health innovation, that is the early health economic analysis. So this health economics will help us answer crucial questions very early in development, like if the innovation is worth it, or for the people using it, if they will pay for it. But coming to this let's say, part of the presentation, we have clear that sometimes in early development, we usually don't have this full clinical data or cost. We don't know what exact outcome we will achieve, or we don't know even what price payers will accept because we don't have clear data from the willingness to pay that we have been, let's say, conducting in the early stage. So here is when the willingness to pay becomes something really useful, because it gives us a first signal on whether there is a real perceived value for the innovation even before the technology is fully developed. So this is why we recommend to perform these studies when you are in technologies like from TRL 4 to TRL 6 in order to guide all the development. So, for example, what are the key uses of the willingness to pay in this early health economic? Because for sure it will let's say, convince investors on the market feasibility, if anyone is willing to pay for the solution, if so, how much, and for which use cases. Also, it will provide some value for our price range in order to be used for a financial model, if we are likely to get pushback from payers or caregivers, and this will help on our final company valuation. Also, it will be the foundation of the cost effectiveness, as we will explain later, because the willingness to pay can help us simulate a basic cost utility model if people are willing to pay for the technology in hospitals, and we can make the economically viable outcome. And for sure, this will also help us to accelerators, incubators, or hospital innovation hub about which innovation should both clinically promise and perceive and has a perceived value. So in order to correlate both aspects, maybe we have to enter a bit about understand the cost effectiveness assessment and the idea, because ultimately payers don't reimburse based on feelings, and they reimburse based on the evidence that the health benefits justify on this cost. So now that we have introduced the willingness to pay and the early health economics assessment, maybe let's dive a bit on some of the most widely used methods for evaluating the economic value of a healthcare innovation. So as you may know, one of the most common approaches is this cost effectiveness analysis, or CEA. So this method compares the cost of an intervention with its health outcomes, measured in natural units like years saved or cases prevented. So this helps us understand how much it costs to achieve a specific health benefit. When those outcomes are expressed in quality adjusted life years, or QALYs, we are talking about a more specific version of this cost effectiveness analysis that is cost utility analysis. This gives us a more nuanced view since it considers both the quantity and the quality of life gain from a treatment. But this is not the only tool that exists in the health economics toolbox. Apart from this, maybe you have here about the examples that we have on the screen, the cost-benefit analysis that goes one step further because it expresses both cost and the benefits in monetary terms. And this allows for a direct comparison between how much we spend and the financial value of the outcomes achieved. And it is very useful when we want to justify an investment purely in economic terms. But also we will have a cost minimization analysis that is the simplest of all, but only if it applies when two interpretations are proven to have equivalent health outcomes. So in that case, it's just a matter of comparing cost and choosing the cheaper option. And finally, maybe you have heard about a budget impact analysis. This method focuses more on the financial consequences on adopting this new technology from the perspective of a healthcare system. And it's less about the value for money and more about affordability. Like, will the system be able to pay for this? And what will the budget impact look like? So as you may imagine, each of these methodologies answers a different questions. And depending on where we are in the development and reimbursement process, one might be more appropriate than others. I just wanted to use the last part of the session in order to explore a bit on the methodology that maybe this cost effectiveness will follow. As you can see, first, for sure, you have to define your model and which specific disease or impairment is being addressed. In the first case, we have this gene therapy for neuromuscular disease. Also, you need to collect all the data and the variables that you want to assess. Include any additional assumption that you have to consider, like, for example, the number of cycles that you have to provide this treatment to the patients, any kind of thing that involves the implementation of this new treatment along the value chain of the patient, the way that this treatment is administered. So all of this is also considered. And for this, you will have the main outcomes and the result for interpreted later. So here, for example, regarding the model, just to briefly explain a couple of examples that normally are used. As you can imagine, there are several types that can be used for assessing the cost effectiveness, but sometimes the 90% of economic evaluations are conducted using either the decision trees or the Markov models, so they can stand as a flagship representative in this regard. So depending on the disease follows a relatively short term and is linear, you will choose decision tree, but if this is a more, let's say, chronic condition with multiple possible state transition, you will choose a Markov model. These are more advanced concepts, but I just wanted to show you, for example, in an easy way, how you can build this kind of decision tree in order to involve the different parameters that are affected by the implementation of this gene therapy, for example, in the patient. So, for example, in order to understand where to gather all this data, you can publicly search on national and international healthcare databases. Normally, the costs are also available from papers. For sure, are all estimations, but you can really do a quick research on the internet and get some papers about other studies that compare the direct cost, about the cost of the treatment or similar therapies, the hospitalization, and other indirect costs. So these variables are used in order to quantify and assign the value to the different states. So all this information can be found public or by paying, let's say, for these different outcomes. But the most important thing is to define which is going to be your model and how the decision tree will evolve among the disease, and to create this standard of care example and compare it with the example of the technology that you want to measure. So when conducting this cost effectiveness, the most important value that you normally maybe have here is the ICER, which stands for the incremental cost effectiveness ratio. But what does the ICER actually do? It simply put it in a simple way, it compares two treatment options, usually the standard of care, any competitor that you have in the pipeline of this development, and the new and innovative therapy that we are evaluating. So maybe this new therapy is typically more expensive because it has some development behind, but it's expected to deliver better outcomes. So either by increasing the life expectancy or by improving the quality of life is why the reason we are conducting this willingness to pay. So this ICER tell us how much extra we need to pay to gain one additional unit of benefit, like this one extra quality, when switching from the standard treatment to the new one. So in other words, it's the added benefit. If the added benefit worth the additional cost. So it will, for example, help us solve some critical healthcare questions, like if we are expending our healthcare resources wisely by adopting this new pediatric therapy or not. I have to say that normally these outcomes of the ICER goes to technologies that are on a more advanced stage, because in order to do a properly cost-effectiveness analysis, even if it's preliminary, you need to know some variables about clinical data that are usually get when you are on TRL 6, TRL 8. So this is more for advanced, let's say, progress of the innovation and not in the early stage, but just to provide you a clear overview about the kind of parameters that maybe some stakeholders are searching for where they want to invest in some new technology. So, for example, comparing the willingness to pay that we will explain before, sometimes specific countries have their own willingness to pay threshold per the quality that you can gain with this technology. So if your innovation delivers a quality for less than that, mostly is considered cost effective, but it can be the contrary case. So these are some of the concepts that the governments or maybe public entities like the EAC Accelerator or private investors, if you are on rounds, can use in order to validate if they will have this return on the technology, if your technology is really cost effectiveness, and in the long term, how much it will impact the ecosystem. So these willingness to pay preliminary studies can give you this insight into how much value users or payers place on certain outcomes, even if we don't have full clinical trial results. So you can start accomplishing these willingness to pay studies, make a preliminary cost effectiveness, even if it's only based on assumptions. And once you are advanced on the clinical development, like TRL 6, TRL 8, and you start getting these clinical endpoints, start to build this accurate health economics that will end in a more advanced TRL on a health technology assessment. So, for example, here we have to remind that the cost effectiveness analysis doesn't just help to secure the reimbursement at a later stage, but also strengthens the investment cases, informs the clinical trial endpoints that you have to include in your value proposition and in the multicentric clinical trials that you will perform, and supports of the strategic and pricing decisions that you are considering. Even when you are conducting the transfer to a new spin-off and you have to build this financial model for Patronato, or when you have to present in front of investors or in congresses why your solution values this money, who is interested in really acquire or implement your solution, and why your pricing strategy and your market estimations are based on the feedback that you have received. So final considerations on the CA is, as I was commenting, in early stage, these methodologies are being conducted from the technological development point of view, and therefore we need to rely on several assumptions due to the absence of data. So that means that the uncertainty is inevitably present in our results, and we must make sure that this is an alive document that you are evolving once you receive more results that are interesting to it. And also you have to make sure that if presenting this into investors, you have to convey that this is only preliminary, and with the support from public entities and private investors, you can refine those numbers after getting the validations that you need in order to show the efficacy of your therapies, how much it improves the quality of life of the patient, and real value that is behind the pricing strategy. So I have just included here some example about resources that may be able to check. For sure, you can find a lot of literature about this on the internet and on different, let's say, programs. This is applied to pediatrics, that you can apply this for any kind of innovation that you are performing. And it's something that you may need to search because you want to combine the science that you are developing with a really robust pricing strategy in order to convince the different payers. So just as a summary and key takeaways, I think that the willingness to pay study must be conceived as a vehicle to better understand the perceived value early, especially in pediatrics. So you have to carefully choose your method and design the study well is critical. And for sure, it will help you to obtain insights about the business model refinement and the commercialization plans that you must follow once you complete those technological actions. So, for example, if you want to start creating this business case, even though it's something estimation based on your last results on the perceived value of your technology after having this conversation with key opinion leaders or a patient association, the first point is to understand what people value. Then you have to estimate what it's worth and why, and you have to show somehow the benefits and justify this price in order to assess which is the real feedback on the technology and why people will be able to willing to pay for receiving this kind of technology or implement it into healthcare system. So I hope that you enjoy the session. I hope I really don't go too fast because sometimes I'm quite fast talking, but this was an overview about the different strategies that you can conduct. I'm for sure happy to take any comments, any questions, or anything you want to clarify in the last minutes. Okay, I see that there are some, I don't know, Raquel, if you will moderate this part. I wasn't reading the...
I can. So thank you very much, Silvia. It was amazing, the presentation, really inspiring. And yes, we have two questions in the chat. One of them is from Joshua. He's asking, how do you find the key opinion leaders for your product? And are people being paid for the engagement with the survey? So if so, are they standardized amount for this? Historically, what percentage of key opinion leaders who are contracted engaged with the willing to pay survey?
Okay, thank you, Joshua, for the question. It's totally a really good one. From my expertise, sometimes around the projects that are being created, you have research centers, universities, or clinical people that is advising on this first stage because they are validating your technology or your next steps. This may be your first willingness to adopt or willingness to pay figures in order to understand if you are really guiding the technology development onto something that is really useful. But I have to say that apart from these close experts around the technology, it's really difficult to have these meetings about direct surveys without paying those key opinion leaders. So companies like Inveniam and other consultancies often rely on these providers of key opinion leaders, that they have a pool of different clinicians that have different expertise, and as you were mentioning, they are being paid for the engagement of these surveys. So that way you also, let's say, can rely that they are using the time that is needed in order to answer correctly and taking the time to think about what you are asking and not doing it a bit like in a couple of minutes and really considering the questions. So I have to say that yes, there are standard amounts for this, and also if you contact directly some key opinion leaders, they may say that they are willing to help, but under a price per hour. So there is this kind of companies that often, like Sermo, for example, that offer directly this pool of more than 1 million clinicians in different countries in order to make sure that you are going to receive your answers. And specifically, if you want to expand your knowledge into other countries like LATAM, I don't know, US, or those ones that are more far to your technology per se.
Just in this line, because I think you as Inveniam, as a consultancy services, now you're offering this, but there are some public funding that support this health economics research.
I don't think so. I mean, for sure, if you are a beneficiary of the EAC, you are entering into this pool about catalog and providers that you may get. Now, for example, they are offering the EAC Access Pros program for the EAC Transition, Pathfinder, and Seal of Excellence winners, where you can apply in order to have a reimbursement of the 50% for this consultancy service. And you can use that in order to build your willingness to pay. So it's true that the European Commission, for those that are EAC winners, is providing this kind of initiatives in order to not only fund your clinical trials or your regulatory milestones, but also to help you this business and more, let's say, strategic decisions to be also supported by other ecosystem. So I'm not aware about a specific call where you are apply and you get this willingness to pay support, but I am aware, as Inveniam is also an EAC beneficiary, that you can hire these services receiving a 50% reimbursement from the Commission. So that way they are encouraging not only scientific milestones, but also these business ones that are aligned and important as well in order to develop and pass into the different tier levels of the technology.
Okay, I think Elena, no, she raised
Yes, I raised my hand just to support Silvia and say that when you present, for example, a proposal for an EIC transition or for an EIC accelerator, you can consider in the work packages that you develop for these proposals for these applications, you can consider in the business aspects, not only developing a technology transfer plan or an exploitation plan, you can also include, in the case you're in life sciences, of course, a health economics and willingness to pay study, or calling it more broadly a market access study, including these elements that Silvia presented today.
Great. And I think that Luis, we can continue with this question as how long does it usually take, to have these huge studies,
Yes, so considering a bit the scheme that I was showing at the beginning, for sure there is this initial part where you have to define really well the objective, the respondents, and who will be the ones answering those questions. And this is a preliminary part in order to understand the technology and to really find those ones. But as I was commenting, as you are normally including a budget for paying all these QOLs, the transition is quite smooth. So for example, here in Inveniam, answering to the question, yes, we offer this service and we are able to do it in about 3 months, 4 months, depending on the technology. And for sure, depending on the scope of the countries that we want to include. Normally, the first thing that we do is to make sure that we are going to be able to really target those QOLs in those countries. And as I was showing you before, that we really get to the QOLs that have the level of influence that we are interested in. Because it's true, as other people is asking in the chat, that if you are consider public healthcare, QOLs may not be the ones deciding on the implementation of new technologies. And that's why we target our interviews not only to key opinion leaders, but also with key opinion leaders with this decision-making influence. So that they are the part of group of people that make the decision on that are close to the reimbursement strategies, or maybe the ones introducing the guidelines on this specific treatment. So that's why we make sure that the people that is answering has a knowledge not only on the clinical side, but also on this reimbursement pathway.
Okay, great. I have a question as a curiosity. How do you calculate the amount of people that you enroll in these surveys to be robustly, statistically robust? Because in the case of pediatrics, sometimes that this illness are not impacting with a lot of children. So you have to take it in account.
For sure, yeah. Here, for example, it also depends on the stage of development that you are. If you are doing a preliminary willingness to pay, maybe you just want to have some general idea about the different countries, and then maybe with this feedback you decide on which countries you are going to maybe direct your first phases of commercialization. So honestly, it also affects the amount of budget that you have, because as we were saying, unfortunately, you have to pay for these interviews. But the idea is that a normal willingness to pay for a preliminary stage, it involves 40, 50 key opinion leaders, including 6 or 5 countries. So at least you have this minimum of 5 samples per country in order to be able to do a statistical analysis in a low rate. For sure, as long as you have more budget and you can include or maybe make awareness of other clinicians that during the development of your technology you will be encountering in different congresses, you can increase this data, and the most the better. But I will say that minimal of 5 samples per country is something that you will need in order to justify your answers.
Okay, great. And we have one extra from Hannes and one from Arnau. Okay, yes. So Hans say, thank you for the interesting talk. I have a question regarding the perspective you include. Do you also take into account the perspective of children or adolescents when they are old enough to able to fill these questionnaires? And what about the perspective of society, to also carry as part of the healthcare cost, or at least this is the case of Belgium. I don't know in Spain.
Okay, yeah.
Yes, how?
Yes. Okay. So normally the first step is to define who will answer your query. In these early stages, let's say, of the technology, you normally include clinicians, because are the ones that first are going to validate if the things that you are doing are really aligned with what there is an unmet clinical need on. And we include then patients on a more later stage when you have a clear idea of the value proposition that you are offering. In the case of adolescents and children, for sure, if it's something that you will need the child to be more engaged, like for example, some kind of software in order to improve or track any mental health condition on child, you can also have these specific queries designed for children when you have to adapt all the vocabulary and everything in order to measure, for example, if the platform will be something engagement and they are willing to use it, let's say, as the end user. But in terms of not the end user, but the customers as buying a therapy or something, it is normally conducted to first clinicians and then the parents. The perspective of the society, this type of willingness to pay is not included, but in some of the examples that I was explaining briefly on the cost effectiveness, you can also consider that. So always when you are doing a cost effectiveness analysis, you have to make clear which is the perspective that you are considering, if it's only patients, if it's the healthcare system, if it's society at all, and at what cost. But yeah, I am not familiar about the case of Belgium, if you can provide further example, but I will say that in the willingness to pay, you are only including the perspective of the people that are answering that, but on cost effectiveness, you normally can go to a more general overview to see how that impacts the healthcare system in general.
Okay, and the last one, I think it was the same like I did it, no? So about the amount of people enrolled in the surveys, no? So
Yeah.
I think that's all. Thank you very much to being here, and stay aware because we will have the next one, the 19th of June. So please be tuned and see you there. Okay, thank you very much. Thank you, Silvia.
So much. It was a pleasure. Thank you. Have a nice afternoon. Bye.